institutions, it is April 1st. We're going to change the calendar here, Tuesday, April 1st. And we're running a little bit late, but we're just getting back after getting our capital bill done. So now we're shifting gears and we're going to have a conversation with our judiciary about the structure of our courthouses and who has ownership of our courthouses. For some courthouses, it's very clear, it's under state ownership. And for some other courthouses, it's county ownership. But when it comes to upgrades to the building, it could be ADA upgrades, it could be power upgrades, it could be adding an addition to a county courthouse. Quite often, that county comes here in this committee looking for construction dollars. So we're trying to really, now that we've got some free time, really vet this issue and see if this is something that the committee would like to work on. So welcome, Terry.
Well, thank you, Madam Chair. Terry Corson, State Court Administrator, and I'm here with Greg Mosley, who's the chair, the chief of our Finance and Administration Division, which oversees courthouses as part of his area of expertise. And Judge Zone mentioned that you were interested in background information regarding county courthouses. So what I have is kind of a background talking about examples of the state either making investments or renovations, additions to county courthouses. And there are a couple of statutes that are relevant that I thought I would refer to as well, just as a broad overview. And we're more than happy if there's specific areas that you want us to delve into or data or whatever, we're happy to gather it. But otherwise, it'll be just to kind of give a broad overview from our perspective of how county courthouses are needed for state court operations.
Do you have copies of what you'll be referencing?
I do.
I'd like one.
Oh, okay. I can hand out if you, the first is kind of I'm going to go through like a chronological type of thing. Do you want me to hand them out now or wait until I get
whatever works for you?
Okay. Okay, great. Well, as you mentioned, historically, county courthouses have been here since the beginning of time in Vermont. Back when Vermont had just the two counties, for example, Bennington County, everything to the west, all the way up to the Canadian border, and Cumberland County to the east. Each county has always had a courthouse of sorts. It might have started out as an inn or a tavern, but there was a courthouse to transact court matters. And for centuries, all court cases were in the county courthouse in every county. Every county had a county courthouse. And then in the 1960s, the first state court was created, which was a district court to cover criminal matters. In the 1960s, that was the first state court. And then in the 1980s, family court was created, which was also a form of state court. In the 90s, the environmental division, a statewide court that covers environmental matters, and the statewide judicial bureau, which is primarily traffic court cases. Then,
so let me stop you here. So the real distinction between the state court and then when the state courts came into play, the state courts, state-owned courts, buildings, that's where the criminal courts were held. And more of your civil was held in your county courts.
Yes, for example, today in the smaller counties, you have one courthouse where all four divisions, criminal, family, civil, and probate, are housed. In the larger counties, typically there's two courthouses, the newer courthouse being a state courthouse that was built as these different state courts were added, and the county courthouse, which typically has civil and probate for the most part. So what happened in 2010 that you referred to, the historic restructuring of the Vermont judiciary, was to unify the state courts and the county courts into one superior court, one statewide superior court.
For the function of how you deliver criminal justice or
Right.
justice to Vermonters.
The court system, right. A unified court system. And again, in those counties that were large counties, you would have typically a newer courthouse, which was a state courthouse. In Washington County, where we are, the Washington County Courthouse down the street on Main Street has civil and probate. And then in Barre, that's the criminal family courthouse for Washington County, a newer courthouse. But we're all part of one court system. And the restructuring was wonderful in many respects because it gave us a lot more flexibility and ability to move things around. A lot more standardization and uniformity because you had one court system. The the chief superior judge, Judge Zoney, for example, he has a lot more flexibility. If you have a case that goes off, a jury trial settles early in this case, he can then have that judge go and help in RFA cases, that we're doubling up. He has a lot more flexibility to move judges from one division to another, to one unit to another. So there are 14 units. They correspond to the 14 counties, and each unit has the 4 divisions: civil, criminal, family, and probate. And even though there are trial judges appointed by the governor in civil, family, and criminal, the probate judges are still elected. They're county judges, county positions, county elections, but they're part of that superior court. So the chief superior judge does have the ability to also move them, and some can be specially assigned, for example, to sit in small claims or to sit in relief from abuse cases. There's just a lot more flexibility, uniformity, so it was a very good thing. But in terms of the county courthouses then, in 1993, there was a provision, and it's 24 VSA 71A, that basically specifies, and I'll pass this out just so we have them here.
Thank you.
Sure. But it specifies that each county shall provide and own a suitable courthouse, pay all utility and custodial services, and keep such courthouses suitably furnished and equipped for use by the Superior Court. So there was that statute that required each county, it says except those provided herein. And it was then amended in the 2000s when in Addison County and Caledonia County, there were state courthouses that subsumed the county courthouse. So those are the 2 counties where there are no county courthouses now. Caledonia was in 1995 to 2001, that time frame. And a provision was added to the statute that says where you have a court building owned by the state, where everything is done, the county shall no longer be required to maintain a courthouse. So that applies in Caledonia. Then in Addison, when the Frank Mahady Courthouse was built in Middlebury in 2006, there was an older county courthouse on Main Street that now is used, I think, by Middlebury College for something. But those are the 2 counties where the county is not required to maintain a courthouse. Otherwise, this provision applies. Each county shall provide and own a suitable courthouse, pay all utility and custodial services, and keep such courthouse suitably furnished and equipped for use by the Superior Court. And the county tax that you mentioned, and I was in a different era, the Rutland County Clerk. So I was involved with the county budget. They meet in December, and it's usually the county clerk, the side judges, and maybe the sheriff. It's a public hearing, but it's one that people aren't typically kind of informed of. But it's the tax to cover the courthouse, basically to cover the maintenance expenses, the insurance, upkeep, minor repairs, et cetera, to keep it functioning in accordance with this statutory requirement. So that is what was there by statute until, and examples of how the state has helped pay for county courthouse expenses. In 2012, there was a big effort to make county courthouses handicap accessible, ADA compliant, the Americans with Disabilities Act. So there was, I think, $800,000 or $400,000 that was given. The statute gave that money so that all of the courthouses could have the accessibility, whether it was for the restrooms or for a ramp to gain access. So that's one example of when state monies were allocated for county courthouse renovations. 2015 is when the Lamoille Courthouse, which was a county courthouse, but it was substantially renovated. Millions of dollars were dedicated to that as another example of modernizing a courthouse where needed. And at that time then, there was another statute, and this was 4 VSA 39, and that's where we come before you all. And this was a bill that was brought about in 2015. I'm going to guess maybe commensurate with the Lamoille work, but basically it's entitled Capital Budget Requests, County Courthouses. And it said that any county requesting capital funds for its courthouse shall submit a request. First it goes to court administrator, then to BGS, to see whether or not it would be included as part of the judiciary's request for capital funding in the annual proposed capital budget request. And it has different criteria, and the 2 the two requests this year for the generator in Woodstock and the generator in Memorial, there's criteria that a request needs to fulfill, and the criteria are spelled out. Whether the funding request relates to an emergency that will affect the court operations and the administration of justice. So that's where the generator and the information regarding that, with the recent storms and the power outages, we had to cancel hearings because there wasn't any way, especially now with electronic filing and all the security, the court monitoring equipment. Without power, you have to kind of shut down. So that was for that criterion. Whether there is a state-owned courthouse in the county that could absorb court activities. In Memorial, no, that's the only courthouse. In Woodstock, they have the other one, but it's under renovation. It's closed down for now. Whether the county consistently has invested in major maintenance in the courthouse. Woodstock pointed to the fact that they floated actually a bond to do their major renovation work. And then Memorial was some combination, I think, of mostly state, but some county funding for their major maintenance. Whether the request relates to a state mandated function, so that would be court operations, state mandated, that would provide courts for the citizenry. Whether the request diverts resources of other current judiciary capital priorities. And I think they looked at the $100,000 versus the multi-million-dollar request and kind of surmising BGS didn't feel that it was diverting resources given the difference in the levels there. Whether it's consistent with the long-term capital needs of the judiciary, including providing court services adapted to modern needs and requirements. So I guess you're saying there's been an increase in the number of these storms that have resulted in power outages. And so that was kind of where that criteria came in. So these are currently what the criteria are that before a county can request capital funding, they're supposed to meet. And then ultimately, BGS weighs in, and then your committee and the legislature, but that's what's on the books now. The other example of where state monies were used for county courthouses were during the pandemic, when we learned that many courthouses met HVAC requirements in terms of air quality and suitability. So there were funds, and Greg has the much more knowledge than I do in terms of how that funding worked, whether it was ARPA or the funding streams, but all the county courthouses are now HVAC compliant, and they meet all the air quality standards that came about during the pandemic. But in essence, we rely on the county courthouses. They provide the courthouses, I say the assistant judges, the county government, rent-free. We don't pay rent. The state courthouses, there's a fee for space payment that the judiciary pays. I say the judiciary pays. We request the money from the general fund. It comes in and then it goes to BGS, I guess. It's how it works. But it's a figure that typically increases year by year, but it's rent that we pay for the state courthouses. We don't pay rent for the county courthouses, and the county is obligated under the statute to pay for the maintenance expenses, insurance, et cetera, those costs. We have also, as part of the modernization with the e-filing, with the remote hearings, also equipped county courthouses to enable them to provide the remote hearings. For example, for security, they have, for example, many of them have the screening at the doors, the cameras for security. That's all monies that we have put in to ensure that we meet the security needs of the court users. But those are some of the examples of kind of the interplay between our county courthouses and state courthouses, all part, though, of the one statewide Superior Court, thanks to the restructuring that the legislature enacted in 2010.
So when that restructuring for judiciary occurred in terms of your operation, do you know if there was any conversation in terms of how we deal with the building and the complete ownership one way or the other? Because right now for county courthouses, it's just kind of
The ownership.
it's just kind of a mushy area in terms of the county courthouses, because we have state functions in there now.
Right.
When the operations of the judiciary were unified under the state, you're doing state functions in county-owned buildings. Was there any conversation that you know of trying to bring all the buildings under state ownership, or how does that?
No, this is the only statute that I know that has to do with county courthouses per se. and monies. I have no idea. And Greg, you probably were,
I wasn't in the
Yeah.
judiciary.
but we can certainly look into, I can check in with people who were, for example, Chief Justice Reiber was on the task force on the restructuring. They went around and had different, listening sessions and all that. I can certainly ask him if that was ever something that was,
Buildings were ever discussed.
yeah.
Because what was happening, what has been happening in the past, is sometimes it would be included in the capital budget, like the Caledonia Courthouse, Addison County Courthouse. That was really, back then we talked about a unified courthouse, a unified system. And then the Lamoille Courthouse. And at that point, up in Lamoille County, at that county courthouse, there was state functions happening there. During all of this time, what we would see in this world, in this committee, were individual county side judges coming before either this committee or going towards their representative or senator, asking for money to be put in the capital bill for their courthouse.
I think that happened is what would happen with Essex.
So this language in terms of what came in 2015, I think it could have been from Lamoille County Courthouse, but I think also there was quite a bit of controversy in the conference committee over one particular courthouse in Grand Isle. It came in and it was seen as bringing home project for someone's particular district. There was some concern about it.
When was that?
I think it was around 2015.
Oh.
It was around that time, controversial in the conference committee. Because it just came in as a project out of nowhere, it seemed like, for some folks. And that's what was really happening back in like 2009, 2010, there was no structure in terms of if there needed to be an elevator put in or there needed to be an addition put on some of the county courthouses, there was no structure. So I think this language in Title IV came about as a result of that, trying to provide some structure for the request for that. And at least it goes to the court administrator, which is you, that they have to request. But there's also times when we've experienced, even in here,
They come directly
they
here.
come directly here.
Mm.
For that. And do we want to continue that practice, or do we want to really clarify what the process is for our county courthouses? For that. Does the committee follow this? So we're just trying to figure out, is it something we need to do further work on, or just keep the status quo and we're going to keep getting requests in? This year we had the Woodstock one came in the capital bill. The Essex one came in the capital bill. And then it was part of the judiciary's recommend for Lemoyne.
That came in later, I think.
It came in later, but
Yeah.
you had it as part of your request when you came in to testify.
Right, they had asked.
Did Essex County work through your office for theirs?
Not initially, they had come, we did provide guidance, I guess, in terms of their working with the local group. There was some resistance to that, but we said, absolutely, you need to work with the local community, in terms of, so we definitely recommended that. But it wasn't something we were, it was more, I think, an initiative of the Essex assistant judges working with their local representatives and senator.
And then it got in through the governor's budget that way, more so?
I don't know.
So I surveyed the assistant judges back in October, consistent with this statute, and that's when they submitted this proposal for that connected. And so
To you folks or to the fifth floor?
it was submitted to us, and then it was included in what we submitted to the fifth floor.
It's a question that we always ask. If you incorporated this in your county budget, if you incorporated this project in your county budget.
Mhm. And I did ask, for example, for the generators, I asked, was that considered for them? They both indicated that, because of the increase in property taxes, they felt that the tax burden was such that it wouldn't have been feasible. For that specific reason.
They come to the state. Kevin?
I was just curious about number two, determining whether the county can absorb costs or the court activities. That's part of your responsibility?
No, it's like one of the criteria, is that what you,
Yes, the criteria,
whether the county could, there's another courthouse that could absorb court activities in lieu of the capital investment. And I don't know if that might be in conjunction with maybe a proposal to add, space. And then the question would be, well, do you have enough space at the other courthouse? If there's another courthouse in the county that could absorb
Okay.
that, so you wouldn't need another
it's
addition?
room more than financial,
Oh, I think so.
right? Okay.
That's my
I'm with you.
understanding.
Thank you.
That's how I
I got it.
interpreted it.
Other questions? Comments?
Sure.
Greg?
One comment, Greg Halsey, Chief of Finance Administration. You discussed Orleans in your capital bill, two courthouses in Orleans, whether there's a relocation or some sort of renovation. That would be similar to what happened a couple of decades ago in Addison. You're either connecting the county building with the state building. We did in Royal or County.
You're talking Newport.
Newport, Orleans County. Or you're finding a new location like you did for Addison County. So these issues will continue.
Mhm.
And it's not gonna be consistent throughout the state. And then if you do something for one county, the other county folks will say, well, wait a minute. If they did it for this county, why can't they do it for our county?
Mhm.
That's kind of what's happening, I would think.
Mhm.
So
So,
another issue, and it's not, like, I really don't think it's purview of this committee, is that the way we have county courthouses set up, and given that doesn't make sense. We just spent $3.4 million, I think, in Essex County, which has 5,900 people in it. And there's a project on hold in Orleans County next door, which is much more substantive. And Grand Isle County is similar to that. There aren't enough people in Grand Isle County to make a house district, or to make two house districts, I should say. And I don't know if that would go to judiciary, or if that would be a government ops thing, or whose jurisdiction that would be.
You're saying consolidate the courthouses that.
Well, it just doesn't make, it's archaic. I mean, Grand Isle County wasn't connected to the rest of the state by bridges until the early 20th century, but it is now. You could very easily split that up between Franklin and Chittenden, and Orleans, Essex could probably split up between Orleans and Caledonia.
I think one aspect of that discussion, if I remember right, had to do with the distance though. For example, if any courthouse was eliminated, the distance that somebody would have to go to be able to access, I think was the reason why it was determined that for access to justice purposes, it's important. That was how the discussion was. Because when you look at the numbers versus how far would a person have to then travel? And from what I remember, it was like 3 hours or something to get to, a courthouse. So I think that was a big part of that conversation.
So what is the committee thinking? Does the committee think that what is before us in Title IV with the structure is clear enough and functions well, or how is it working internally in your office, Terry? Because you're the court administrator. Are you getting a lot of requests coming in from counties?
No, and I've been 2 years in this, so I don't have a wealth of experience. But for example, this year, those were the requests that were made. And I don't know, maybe I don't have a good idea of year to year how that varies.
Yeah, so I came on in 2017, so I have a pre-pandemic experience, and then the post-pandemic, it's been very different. Pre-pandemic, we had a very small amount of money in our budget as tenants in all of these buildings to do some sort of maintenance or reconstruction. Usually that was build a step here or remove a railing there, something that made the courtroom itself function more properly. And we had a couple of handyman contract that would help us out. Then in 2020, there was a greater need with all the HVAC. And the funding, the federal funding was not given, was not made available to towns or to the state through that ARPA funding. And so the solution was for us to ask for the HVAC funding and then oversee the projects in all these 12 courthouses. And so since then, we have now 3 project managers on contract that help us in all these 12 counties and continue to help us with the remaining HVAC work, which is ending. Then with our new network, we've wired the buildings. We're now putting in extra hardware, the remote hearings. And so there's been a lot of activity since 2020 where we are really managing facilities much more than we used to.
Troy and then James.
Would it be helpful if, and I don't, maybe this is in the works or it already exists, but is there like a 10-year anticipatory listing of projects that, so that it's always kind of on the radar, especially of this committee, for what we can anticipate being asked out of the capital budget? That's what I'm wondering. Is this works, right? And it's clear to me that there's an obligation that the state has to be responsive to the list provided. But it might be beneficial to have a 10-year plan or something like that. Yeah.
I don't know, but are we saying it opens it up for construction projects for
Right.
county courthouses that come here?
Well, I mean, it's kind of already in
County
there.
budget?
I guess it's not in there that we have to do anything about it, but the request is kind of in here, right?
But we know as well as you do, if the court administrator doesn't sign on to it, you know where they're gonna go.
No.
Probably tell local legislators.
Just want to put that on the table because that's happened.
Said the long range planning, that's what I think for these courthouses, you know, whether it's Orleans or whether it's the ones that vary. I mean, there's a handful of courthouses that it's clear that work needs to be done, but for a variety of reasons, it's not clear whether it's renovation or rebuild, and that's what's on the long range list, if you will.
How many requests did you get? That's one thing that I did pick up on here, is that on or before January 15th, court administrator shall advise the House Committee on all, and, you know, of all county requests received and the recommendations for the proposed capital budget.
This year was the 3. Were the only
That was
3.
all of them?
Yes.
Oh, okay.
Yeah.
So it's not like you said, these 3 rose to
No,
go.
in the year before, I don't know honestly remember if there was.
I don't think there was a 2-year cycle ago. I don't think there was any requests coming in. Actually, 2 years ago, it would have been in the middle of the pandemic, so they were pretty grateful and thankful for our effort to put the HVAC systems. And the HVAC systems involved a lot of extra work, from installation to upgrading electrical, reinforcing carpentry. So there was a lot of these old buildings now have much newer systems, from computer systems to HVAC to security, badge lights, and it's funded it through the legislative appropriations, either general fund or bonding dollar. And we've also taken on the work of kind of overseeing the projects and managing subcontractors. Even though the side judges maintain ownership of buildings, everything we do in there, we get their approval on. So we come with a plan and they say, yeah, we've literally had side judges say, don't drill your hole here, drill it over there. Wire over there. We've done it.
James?
I think my position is larger than this committee, but I think we as a body should explore one of two things. One is, I know is already being explored, is transitioning to a strong county government, in which case they could have ownership of these. And there'd be a budget, et cetera, to run that. Or going to a system where it's all state and it's not county. So it's unified that way. One or the other, I think should happen in time, whether it happens anytime soon or another 15 years. I think those two things should be on the table, and both probably strike me as a better option than what we have, which is, I think, convoluted in ownership at least. But
State function, we have state function in a county-owned building.
Yep.
That's what we,
yep,
well, and then,
I was the only member of the public at my budget hearing in my county.
You would, okay.
So, yeah, you're right. Most people don't think about this, but I see why the counties come here because they can't raise that money on their own because I believe there's judicial precedent that prevents them from being able to raise the kind of money they would like to be able to fix up the courthouses to their liking. Am I correct on that?
I don't know if there's restrictions, but the county tax is generally a very, very small
Yes.
tax.
Okay, but they're not allowed, for example, to create their own grand list and collect it that way. They have to go to the towns and use their town grand list, correct?
It's a percentage, a very small percentage based on, I think, isn't it subject to approval though at the towns within the county?
No, I think the county can
Yes.
tell them, but they're usually, I mean,
Automatic.
I'm sure it's negotiated, but I guess that would be the central question to what we're, discussing here is if we do want to maintain that county presence, ensuring that they can go ahead and do that. But I think that's a government operations question of whether or not they can, put have a county grand list and be able to raise funds for that. But
Isn't there a committee that's kind of studying?
there is, there's a
governance?
committee that's looking at the governance issue and county issues, trying to see if we do go to a situation where counties have more, where we start putting back in county government, because we really don't have county government except for the side judges. That's it, and a little bit of the sheriffs, but
I think
not
it's
much.
the courthouse and the sheriff.
So Connor and then Joe?
Yeah, sure. I think as I'm looking at this, I believe it works well for our purposes right now. I am worried about the future and just looking at the capital bill when we pushed a lot of things back in our 10-year plan. And if an Essex comes in, 6 years from now and asks for 3-some million, I'd be afraid we say the bank's closed at that point. So I'm worried about the future and if we have to start thinking about that. And the vice chair, I really agree. If those conversations are happening with county government, the role of this committee might be elbowing our way to the table on that and making sure this is part of the conversation with the county government. So if it's GovOps or whoever working on that, I think we should
There's a committee that's set up to meet off session to look at this for that.
And partly because federal funding oftentimes is county specific. So I'm basically wondering, are we losing out on?
I think it all started because of the issue with the floods in FEMA. It's all coming in through the county level, as well as a lot of ARPA dollars were coming in through county. And that's where we were having some issues. Joe?
But county budgets are not, there's no cap on what a county budget can be, and nobody votes on them, aside from the assistant judges. If you don't like them, that's just the way it goes. They counties send bills to the communities, I think based on a per capita basis.
That's part of your town budget.
And most people don't even, unless you're on the select board or the city council, you won't even know what it is, and it's usually a really small line item.
So is this an issue that folks want to do some work on or
I don't
not?
think so.
Just kind of,
No, well, it's because, it's not that I don't,
Yeah,
if we had had these a month ago, I would have said, okay, that's great.
go ahead.
I would say just maybe drafting a letter to the summer committee from our committee, inserting this in the conversation. I don't mind being lead on that, even I can take a stab.
Kevin?
Well, I'm just curious, if, aren't we working on one courthouse that we can't expand because there's no parking and we're trying to,
It's down in, Washington.
so we.
But
state
we own
owns
that, but we own that.
That's
State
fully
owns
owned by
that.
the state, and that's why we're, okay,
Yeah, but these are county ones that we don't own.
right, yeah, no, I'm with you.
So like in Windsor County, the one in White River, we own.
Yeah.
The one in Woodstock, we don't. And I'm trying to remember, Greg, I think it was 2 years ago, maybe 3 years ago, the side judge from Windsor County came up asking for money. I think it was for an elevator for the Woodstock courthouse. It was towards the end of the session.
It was more than a few years ago.
Was it more?
I don't remember what year that was.
Was it pre-COVID or after? I thought it was after.
Pre-COVID.
It was
They have a
pre-COVID.
condition on the back of the courthouse that
Yeah.
has stairs and elevator and the accessible entrance.
And they came in after, I mean, I think it was in April. They came in wanting money.
Remember what year that was?
Yeah, but they went to their legislators and saying,
7, 8 years.
and it may have come out of the general fund at that point
Yikes.
for that, but it came to the legislature like in April.
They got it?
They got it.
So
It
that's
depends,
did it
it depends who your
Right.
legislators are, where they're sitting.
So did it bypass this?
Did you bypass the entire committee and everything?
Now, they came in, I remember this, it was in April, it was towards the end of the session.
Excuse me.
Towards the end of the session. I think the money came in through the general fund, and yeah.
The other thing that will likely happen in the future is, weather and power outages. And we are more power dependent than ever since we are using computers, X-ray machines. And so today Addison County is closed because somebody hit a pole. They don't have a backup generator.
And that,
That's a state building, but
right.
most of
Well,
these
that's a
courthouses-
unified court. That's one of the first ones we did in the 90s.
I wonder if BPS might be looking for generators at the state courthouses, then if they don't have them now.
Few of the courthouses have backup generators, very few. Some, but pretty interesting.
You almost think that would be a given,
That's what I would think too, but it's apparently not.
even at the state-owned ones.
Right.
Well, just a few years ago, we had plenty of paper that we could still work from,
Right.
and ventilation is not a concern.
So the Windsor County Courthouse, the one you're redoing in White River, that's a $15 million project. Is there gonna be a backup generator in that one?
It's too agile.
That's a BGS question.
Yeah, no, it makes perfect sense, too. Well, the main thing too is restrooms. I mean, that when you lose your power, that's the other issue there.
Restrooms don't work.
Right, and running water, and so that's why they might have to shut down also. Well, I'll ask BGS if there's plans in the works for that, because it only makes sense to have that option.
It just is kind of frustrating on the construction building end that when there was a unification of the court processes in your system, the buildings weren't looked at to really clarify under whose jurisdiction is this.
And I'll check with Chief Justice Ryber, because he was part of that.
It'd be interesting to find out because back then it was really strange how there was some state functions in some of the county courthouses, and it wasn't unified in terms of what would be covered in those agreements. In some places, the state would be picking up the maintenance. In other places, the county would be picking up the materials of the paper that was used and the maintenance. I mean, it was just this weird, depending how it was negotiated with who was at the table.
Maybe that's what led to this bill that talks about them providing utility, custodial services, et cetera.
On the utility front, an interesting piece of that is the counties used to pay for a phone system and continued after unification to pay for the phone bill, essentially utility. But then ADS converted that to a VoIP system, so it basically became part of our computer system. And we used to get the phone bill and then bill back the counties for that cost. We used to send the bill to the county for the phone bill. But then ADS was not providing line-specific information, couldn't bill them. So the billing of phone systems ended for that reason. We still don't. So the counties no longer pay for the phone. The phone now is incorporated into the computer system, and everything computer oriented, from the printers, copiers, and phones, has to be compliant and secure. And so it's all state now.
There was an addition to 2471A, I'm going to guess right after the restructuring. It says the county shall provide at least the facilities for DEF operations that it provided on July 1, 2009. So I think that's to make it clear, if you provided it then, you're to continue providing it.
We've had a lot of perk skirmishes, I would call it. Side judges want to move into a new office. They want to expand this. They want the parking spot back. This is your printer, not ours. Pay for replacing that. There's been state inventory tags placed on county leased copiers by accident. I mean, little tiny annoying problems.
But that's because it's not clear
Right.
under what jurisdiction that building and operation, well, some of the operations are under when you have state functions. In that building.
Madam Chair, I apologize. I'm scheduled in another county at 2. I don't know what the protocol is.
Oh, you'll be all right. We'll be.
Okay.
Just a quick question. So fees collected by the court are state, belong to the state of Vermont judicial system.
What is the fees,
So-
filing fees?
Yeah,
That goes in the general fund.
and there's no peel off or revenue sharing with the county.
With the
For those?
county? No, I don't think the county gets any.
Unless they run like a passport office and they charge their own fees.
So I think that's pretty limited. I don't.
Yeah, any fee that we collect in the court system comes to either the state or the special funds, state special funds. Yeah.
Thank you.
So the county, whatever function the county is providing for that courthouse, county owned, is through the county budget.
Maintenance, utility.
Their state function. The operations that are occurring in that building are state. Because we unified the criminal and the civil and the family and the probate. They're all unified under the superior judge and the court administrator. But a portion of that is operating in a building that is not owned by the state. It's owned by the county. So then when there's work that needs to be done in the building, who pays?
The county would be paying for upkeep, maintenance, et cetera, those kinds of expenses. The structural expenses, if you will.
Till it gets to a point that they can't afford it as a county level, and then they'll come here.
Yes.
Or if it's a security issue, I'm thinking of Chittenden civil fence, the perimeter fence.
So they paid for that.
We shared it.
We shared it, yeah.
Share the cost because it was protecting our employees who there's issues in the.
There were
parking lot.
issues.
So it's issue specific. Whether there's,
Definitely case by case. Approach, things like that.
any other questions? So Terry can head out to the next committee.
Well, we very much appreciate it. So, and please, if there's other specific data or information that you would like, we're happy to provide it. I'll check with the chief in terms of
Okay, great.
that question and,
Maybe there was an answer to it, or maybe it was just an oversight. I don't know.
I'll check with BGS about the generators.
Yeah, the answer. Particularly the Windsor one. The White River, doing all that work.
Right.
Great.
Thank you all.
Thank you.
Thank
Thank
you. Peace.
My pleasure.
Taking 10 pounds during judicial retention.
So we're gonna shift gears a little bit. Katie, we haven't seen, when were you in here last? I think a good month ago.
24.
So you're gonna have to start from scratch. Oh, no.
You like the cookie?
Oh, no.
Thanks. Those are good cookies.
Always
are.
Very good day.
Yeah, okay. So pull out your file on H32 if you have a file. And we had a whole checklist that you worked through with us.
Oh,
Maybe would you like a cookie?
Thank you. No, but I know Terry's cookies are very good.
On the way out.
So Katie, are you gonna go through that checklist at all? Or do you want me to just give a broad?
It's up to you. But I could, it might be a nice reminder of where we were.
I think that's gonna be important for folks.
Okay, let me switch my documents around here.
Knowing the committee, I think it would be helpful.
Okay, great. Katie McLean, Office of Legislative Counsel.
So we also have a new draft. Well, before I hand out the draft, I think what I'd like to do is make sure folks can focus on what we discussed and where we were sort of at with some of these. And we don't have to go into detail. I think this is just a reminder for members.
Okay,
So Katie, it's all yours and welcome.
great, thank you.
Good to see you back.
Thank you. Congratulations. You had a big day on the floor. Your big bill is out.
We already have this.
Oh, I know, but.
Yeah, I'm gonna wait for the members to go through this and then we'll get the draft.
So just a high level overview, you had a bill that you were working through, I guess, a month ago. There were a lot of concerns and issues that were being raised, so we decided to take a step back and just look at some of the policy issues and try to make decisions on some of the specific decision points that were sort of pulling us in multiple directions. I tried to take everything I heard and went back to my office and I tried to put it into a draft. So that's what I have for you today. But in terms of going through some of the issues that we collectively worked through, we looked at what is the problem that we're trying to solve. We were discussing whether the services for MOUD were inadequate. There wasn't parity with the community. Are we looking to improve diagnosis? Are we looking to reduce diversion? And I think for a lot of these, the committee's response was, yes, we want to improve many points on this list. Who should be responsible for the delivery of MOUD in correctional facilities? We talked through a lot of different options, but in the end, an entity under contract with DOC, sort of maintaining the status quo, is where this committee landed. Roman numeral 3, when and under what circumstances is a person screened for OUD? Much of what is in statute was retained for the screening, so there weren't a lot of changes there, some reorganization, but not substantive changes. What MOUD medications are provided? So right now there's language about a person is initiated on buprenorphine. In certain circumstances, they can transfer onto methadone. The committee decided that any drug that is authorized for MOUD doesn't have to be specifically named and called out in statute. Instead, we could just more generically say a drug that has been approved for use for MOUD is appropriate. So you'll see that change in the draft. Who receives MOUD? We had a little bit of a conversation around inmate and detainee. So you'll see we have the addition of a definition of detainee, and that term is used in narrow circumstances, specifically when somebody is being discharged. The DOC in this draft they have to provide medication to an offender who is leaving, but they may provide it to a detainee. So without the language, it sort of leaves that group of individuals out of potentially leaving the facility with medication. So this keeps the door open, and in the right circumstance, they could receive that medication. How should reentry be addressed? That is something I think we're still working through. So we do have some language about reentry. We'll go through it. But in terms of case management, I don't know if we had wrapped up that conversation or if that was sort of something the committee wanted to look at more. Another one for more discussion, the committee had briefly talked about whether correctional staff should have training on medication for opioid use disorder. And there wasn't really a decision made. So I sort of have it flagged in the draft that you can add it, you don't have to add it. But it's something that we didn't reach a conclusion on. In terms of data collection, what data collection is necessary? The committee talked about this a bit. I do have sort of some placeholder language that I put in, but I also have flagged that as something that might need some fine tuning or more thought from the committee. So that is where we left things when I was last here.
Are there any questions before you get the draft on that? Hi, Tony. Troy.
I don't want to presume what the draft looks like, but I'm gonna want to make sure that we don't create policy that paints us into a corner as OUD becomes more and more, as it evolves. I'm thinking especially of injectables. Yeah, I'm sorry, I don't have really any fully framed thoughts right now, but I just want us to stay on the front line of this, best practices. So, and I think the field of delivery is changing and evolving quickly. And I know I'm probably on a bit of an island here, but incarceration is costly. And I don't want to cut costs where it will aid recovery and treatment for folks that we incarcerate, meaning despite the fact that the injectables are costly, I don't want that to necessarily immediately close the door on our use of it. So I just want to be flexible. I don't want us to paint ourselves into a policy corner here.
Anything else? There you go, folks. So this is a strike all to the bill as it was introduced. Strike all to age 32, based on these policy decision checklists that Katie just went through, that we worked on back on the 19th of February. So it's a long time ago.
Yep, 19.
So Katie, it's all yours. If you could give us a walkthrough.
Sure, happy to.
The bill.
As just to refresh your memory, there are two main sections of statute that deal with healthcare delivery in a correctional setting. And we had walked through and spent a lot of time with both of those. The first one is medical care in general. And then the second one is more specific to substance use disorder and MOUD. So I just want to remind you of the lay of the land when we're looking through this. So the first section we're looking at is general medical care of inmates. No changes in this first subsection A. The department is to provide health care for inmates in accordance with the prevailing medical standards. When the provision of such care requires that the inmate be taken outside the boundaries of the correctional facility wherein the inmate is confined, the department shall provide reasonable safeguards when deemed necessary for the custody of the inmate while the inmate is confined at a medical facility.
So for all healthcare,
All healthcare.
the department needs to provide healthcare for inmates. And the inmates is both detainees and offenders, is both those who are sentenced and those who are detained in accordance with the prevailing medical standards. So there's no definition of prevailing medical standards, but it's interpreted whatever's received out in the community for medical whatever people receive for medical practices or medical procedures or not coverage, I don't want to go into that, but would be the same in the facility.
Correct.
So whatever we receive, a detainee and a sentenced person would be receiving the same while they're incarcerated. Connor.
Just looking at healthcare practitioner, Katie, is that defined? Is that
You're way,
oh, I'm on the page one.
yeah.
Oh, okay.
You're not there yet.
I was going to go there next.
All right.
Hey, I want, because we have new folks to this world, and this is reading the language and then understanding what's currently in practice and currently the law.
I just got really excited.
That's where I'm going to go next. That one of the changes you'll see throughout this draft is the use of healthcare provider. The two sections refer to providers in all different ways. It's very inconsistent. Sometimes we list certain providers, sometimes we use sort of a general term, sometimes we use two kinds of general terms. So I've used healthcare practitioner throughout and I've added a definition. You'll see it when we get to it, but the definition is meant to be broader. So it refers to anyone licensed or certified by OPR or the Board of Medical Practice to provide healthcare. And then you'll see that if the person is making a decision, not just doing an exam, but making a decision about whether somebody should receive a medication, be discontinued from a medication, then they have to be a healthcare practitioner who is licensed to prescribe that particular type of medication. So that's how I've handled it in the draft to create some conformity throughout.
So it went from healthcare provider
Mhm.
to healthcare practitioner for more consistency in terms of current law.
Mhm.
Use provider in different ways.
And these two statutes, it seemed like we were jumping around a lot in terms of our terminology. And so like at one point, you'll see, not maybe even on the next page, there's a point where we list certain professions, which sort of begs the question why those professions and not other professions who are also prescribers. So instead of having different terminology for healthcare practitioners, I thought it would be cleaner to just use one term consistent in both statutes and define the term.
So in both statutes,
Yeah.
what you're referring to is what you said earlier. There are two main sections that deal with providing medical care
Mhm.
to folks who are incarcerated. One section, which is on page 1, line 8, section 801, medical care of inmates. This is the overall medical care.
Mhm.
The other part of the statute is later on in the bill that deals directly with MOUD.
Yes.
So that's what you're referring to when you're saying consistency between the two statutes.
Mhm.
Got it, committee?
So I
Kevin?
thought I had it, and then I sort
Yep.
of, did you define prevailing medical standards?
There is no definition.
So in the absence of that, this seems overly broad.
Basically, I think the interpretation is for whatever you and I get for medical care, a person who's incarcerated will get the same.
Okay, so and I'm not trying to be light on this, but if I wanted a nose job because it's too small or too big, right now, if I want to pay for it, I can go to a plastic surgeon and have that done. If you are an inmate, who makes that determination?
Medical provider would make that. It would be WellPath. It would probably be WellPath, our contractor, but they would also have to work. And Haley, I'm gonna look to you. They would also have to work with the director, Dr. What's his name? Uliger, for approval. What's that?
He's a WellPath staff.
Right, but he's based out of central office in
He's-
Waterbury.
Based out of central office, which is also in Waterbury.
Okay, so would he have, if there was a situation like, what was his perspective? For a person who's incarcerated wants to have plastic surgery on their nose. They'd have to work with WellPath.
Mhm.
Would WellPath work at all with central office for DOC? For approval, or is it totally up to WellPath? Because it'd be based in their contract.
Yeah, there would likely be those conversations. I don't know whether there's any discretion over whether provision of medical care. I think that's solely up to a healthcare provider.
And the contract that DOC has with the provider,
Yes,
what the provider is to provide.
yes, and that's all outlined in the contract as well.
And the contract's about this thick.
Pages.
Connor?
So, yeah, Katie, just going back to the definition there with like sort of the OPR
Hmm.
occupations under the practitioner. You know, I'm worried if we're trying to get like equal care with the outside a facility, inside, you know, I would get a physical from a doctor, right?
Mhm.
I'm wondering, would this definition allow like a medical assistant at WellPath who's certified under BPR to perform that physical?
I mean, like a physician assistant, yes, but a
Yeah.
physician assistant might be doing that in the community.
Right.
You're
Yep.
not seeing a doctor for your physical.
Nope.
You're seeing a PA for the most part.
And if,
Did yesterday.
Well, you're lucky. Most times you're seeing a
Yeah.
PA under a doctor.
if you're concerned about the definition, I have to pull it, when we get there, we can look at it more closely, but we could add something like a person acting within the scope of their license or their certification, so that the person would be limited to doing tasks that they're licensed to do. So if they are licensed to do a physical exam, then that is the person who would do it. So I think it's implied sort of the way it's written, but there's no reason why we can't add something like that. Yeah.
Thanks, Katie.
So this section, little b, deals with a person when they become incarcerated, when they come into a facility. This happens, I would assume, at booking. That if they're going to be admitted to the facility for a minimum of 14 consecutive days, they will be given a physical assessment upon entry into the facility, correct? And at that time, they would also be screened for substance use disorder. And that would be done in booking, correct?
Statutory change that's being proposed here is right now you have a subdivision B2 that talks about screening for substance use disorder. Top of page 2. This language is being struck not because it's going away, but because when we last met, there was an interest in trying to do a better job of keeping the first section as medication or the practice of medicine generally in a correctional facility, whereas the second section was specific to substance use disorder. So I've moved this language to the next section, and instead I just have a cross-reference here at the bottom of page 1 that screening for substance use disorder shall be conducted in accordance with 801B of this title. So that subdivision B2 is not eliminated, it's just moved to sort of categorize the different types of treatment better, if that makes sense.
So when they come in, they'll have their physical assessment, but within 24 hours, they will be screened for substance use disorder. That's what lines 18 through 20 are saying.
Mhm.
So we didn't lose the 24 hours, we just moved it to the other statute that deals with MOUD, which is on page 6. And that was probably put in, give them time maybe to assimilate, maybe they're going through detox. They may be in a facility for very long. If they came in on a Sunday night, they'll be arraigned on Monday, so it's not the full 24 hours. That's why it's done a little different. Questions?
The subsection C deals with emergency care that hasn't been touched. Subsection D has to do with policies that the department is adopting on healthcare. We're not touching that. Subsection E, this is pre-existing prescriptions and then definitions for this subchapter. So this is one of the places where we call out particular groups of providers, which is different than how it's handled in other places. We like this list.
I wondered if this was one of those places.
It is.
And I think this is someplace where I think we'd have to take some real testimony, because I remember when we put this in place. This is to ensure that if someone's coming in with pre-existing prescription, I want to make sure by switching it to healthcare practitioner, it's it's not gonna create a problem, because we spent a lot of time on testimony on this. Because it may not just be coming through a physician. It could be coming elsewhere as well. And sometimes some of the testimony we received, a person would say, oh yeah, I got a prescription, it's down at this pharmacy. I've been dealing with it for years. And WellPath, or the contractor for DOC, would call the pharmacy and it's like, no. It's old, it's a year old, person hasn't picked it up. So there's gotta be some connection back to a person that actually did the prescription for that inmate.
I'd say a healthcare practitioner prescribed the medication.
I don't know, that's what I really want to be clear.
I want to direct you to put lines 6 and 7 on page 3 to see if that gets to what you're saying.
I don't know, I know we
This-
spent a lot of time. It's licensed to prescribe medication.
You want to just put that here as well? I mean, this is all the same, subsection 1.
I think we have to,
Troy, are you saying to license to prescribe the medication, add that?
Yeah, I'm just asking, I guess, if that is enough for the chair's concerns.
I just know we spent a lot of time talking about it in testimony for it. And I'm not saying healthcare practitioner isn't appropriate. I just want to make sure we don't change something to make it more difficult to track where that prescription originally came from. Because sometimes the information at booking is given incorrectly. Sometimes it's legitimately incorrectly, and sometimes it's purposely.
We just, okay, there it is.
So what is the law regarding that now?
It's what is crossed out. It's the current law.
In some ways, you can actually almost get rid of on line 18 healthcare practitioner and then it would read, except as otherwise provided in the subsection, an inmate who is admitted to a correctional facility, we'd have to get rid of that, admitted to a healthcare facility who is taking
No,
prescription medication.
you gotta have the medical care. Okay, you gotta have the medical care. Because the testimony we received, it's really, really dicey, the information that can be given. When a person's coming in for booking, you've gotta have that medical backup for the prescription. It's really important, because there's information that's given that's not accurate. I'll try.
I'm gonna jump ahead here, but I just want to read healthcare practitioner definition. It's on page 4, line 7. Means an individual licensed or certified by OPR or Board of Medical Practice to provide professional healthcare services to an individual during the course of that individual's medical care and treatment. That just feels fairly comprehensive.
I think I'd like to hear
Yeah.
some testimony from OPR, the Board of Medical Practice, just to be sure. For this,
That's a great idea.
yeah. I just am really, really careful with it because we spent a lot of time, because this is the committee that put together pre-existing prescriptions. And to make sure that if anyone's coming in on a prescription, that that gets carried through while they're incarcerated, because there was a lot of issues happening where they were not. And some of the prescriptions were being substituted by other formularies. And it just was, it's a very involved conversation. And we spent a lot of time on this when we put together the language in E1, that came out of this committee. And I think you were with us, weren't you, Katie, for that? And we had to be very, very specific.
So, and I can't remember what Dr. Schatz said. I mean, he must have said something regarding this. I just don't recall. But potentially there could end up being just a desperate number and types of medications at some point in time resulting from this language. Because
You know, what do you mean?
if there are various medications that were previously prescribed to someone in the state, and I'm not saying whether that's good or bad, but whether or not WellPath or a successor has to adhere to that, but it just might make it a lot more complicated for them if they've got 15 different medications they're keeping track of for, I'm just making up a number for incarcerated population, then
Well, this is when they're coming in. So if you look at the language, E1, this is when they're coming in, when they're admitted to a facility. WellPath has to make sure that whatever medication that person is taking at the time of admission is pursuant to a valid prescription. And that's really important that it's valid, because sometimes they'll tell you, oh yeah, I have a prescription.
It's expired.
And then when they checked, it's like, well, this person hasn't taken this prescription for 5 years, or, well, yeah, they're supposed to be taking this prescription, but they haven't come in for medical checkup. So there's all sorts of things that the person who's coming in to being incarcerated will tell the provider. The provider has to be able to backtrack and check. So that's why it's very clear it's a valid prescription, which is verified by the inmate's pharmacy of record, primary care provider, other licensed care provider.
Yeah.
Or verified by the Vermont Prescription Monitoring System.
Other prescription monitoring systems,
Because a lot of times
different state system.
the contractor in DLC will be told what they're on. The inmate will tell them, yeah, I'm taking this, I'm taking this, I'm taking this, and they're not. They're not, they just want to
Gotcha.
get it.
Yeah.
They want to get it.
So they can.
So you gotta have a process to legitimize what medication they're on,
Gotcha.
because you want to continue it. But we were very, very clear on the language.
When did you take that testimony? 2 years ago?
Oh,
Last year?
God, no, that was 17, 18. It was,
Okay.
and it was
Oh, okay.
pre-COVID.
Before a lot of.
Yeah, well before COVID, I think.
Yeah, well, we spent a lot of time on this. Because we wanted to make sure that if someone has a valid prescription and they become incarcerated, that that is continued. But you have to validate that that prescription is valid,
Yep.
because there's a lot of games that can be played.
But isn't WellPath doing that anyway? Or no?
You want in law.
That's current law.
Right.
What we're changing here is instead of calling out these three specific professions as somebody who the person is in the care of prior to coming into corrections, we're saying healthcare practitioner generally. So instead of being under the care of a physician, physician assistant, or an APRN, they're under the care of a licensed healthcare practitioner, which is licensed, yeah.
So that's where you would have either OPR coming in, as well as Board of Medical Practice to come in and testify to us. What's the difference, if there is a difference?
Okay. So we gotta see somebody, right?
Getting some expert feedback.
Other questions? Thoughts? Okay.
So at the bottom of page 3, we've just gone through all the places and ways that a prescription can be verified. And then on line 3, it says that the person shall be entitled to continue the medication and to be provided that medication by the department pending an evaluation by a healthcare practitioner licensed to prescribe the medication. So instead of those 3 particular professions, somebody who by state law can prescribe the medication in question has to do the evaluation. Similar change in subdivision 2, nothing in subdivision, notwithstanding subdivision 1. DOC may defer provision of a validly prescribed medication in accordance with this section if in the clinical judgment of a healthcare practitioner licensed to prescribe the medication, it's not medically necessary at this time.
So who would make that decision? The person on the outside?
No, I mean, this,
Person on the inside?
yeah, so it'd be
Make the determination it's not medically necessary to continue.
and that's a person who's licensed in Vermont and they're licensed to prescribe the medication in question.
So for Ally, I'm just gonna ask this question. Probably obvious for the answer, but is everyone within WellPath that can make this judgment that this prescribed medication is not medically necessary, are they considered healthcare practitioners licensed to prescribe the medication?
Are you thinking specifically of MOUD? Or
No, this is
general, yeah.
We're in the
I wanted to
general.
make sure.
right now. We're in the general. But you're not sure, you're assuming that, right?
I'm just thinking of like certain psychiatric medications and who can prescribe those. So it would have to be somebody licensed to prescribe those specific medications, but arguably that's has to be the case now, otherwise they couldn't be prescribed in a correctional facility now.
Is this notion of being medically necessary, I mean, here we're talking about prescriptions, but going back to Kevin's question on page 1, is that part of prevailing medical standards, that it be medically necessary? The nose job question, you know?
Yeah. I mean, that was what I was thinking when that question came up, that there's sort of, it's implied that it's a medically necessary service and not an elective service. With that said, I don't think it hurts if you want to look at subsection A again. And if you want to work the concept of medical necessity into that paragraph, I don't think it alters the current practice, but it's a nice guardrail.
I would certainly want to be more specific.
Like deviated septum, yes, appearance, no, kind of thing. Yeah. Yeah, no, I see what you're saying. I see what you're saying.
I'll flag it. Okay. Shall I keep going?
Yes.
Okay. So we're at subdivision 3, and the change here is that the term used to be licensed practitioner. So for conformity, I'm changing it like everywhere else to healthcare practitioner. We're striking licensed because that's embedded in the definition of healthcare practitioner, so we don't have to say that there. No other changes there. And then we get down to subdivision 5, which is our definitions. I should just flag from an organizational standpoint that I didn't think of this until I was sort of rereading this to come back in today. But this subdivision 5 used to be the very end of this section of statute. And last year, 2 years ago, you added a couple more subsections. So now you sort of have this like definition section embedded in the middle of all this policy. It feels weird. It looks weird. So we could either put it in a standalone section or we could just drop it down to the end of this section. I think either would work. But I think just the location of it is a little weird. Yeah.
You ever list it first so that people know?
Usually it's first.
Sometimes it's first. It depends, actually. So if you're drafting like a new section from scratch, I would put it first. But often if it's an existing statute and then we start dropping in more language to it, that's when it sort of ends up at the end. I don't think either placement is unusual. So if you have a strong preference, I can do whatever you want. But
I think
here,
it would be nice,
here it's
especially
strange.
if we're going to be using healthcare practitioner, it might be
Uh-huh.
nice to have that defined ahead
At
of
the top?
time so
Okay.
that you know what it is reading.
Great, thank you. So as I mentioned earlier, there's a new definition of detainee to mean an individual incarcerated while awaiting trial.
I saw it.
Healthcare practitioner, we've already talked about a bit. And then no changes to the definition of,
I want to go back to detainee.
okay,
There are folks who are sentenced who are also awaiting trial for a new crime.
okay.
That's why there's a difference between inmate and offender. Inmate is defined to incorporate that it's the detainee, and offender is both an inmate and an offender. their sentence. So detainee, yes, they're awaiting trial. But for some individuals, they're serving a sentence for enough. They
Well, we
could
could
just
just say
say
in-
been out on furlough,
Who has not been sentenced for another crime.
but they could, this is where it gets dicey. It would be really helpful to work with DOC on this.
Sure.
Because they could be out on furlough, they could be out on parole. They've been convicted of a crime. They're serving a sentence. And part of that sentence, they could be on furlough, they could be on parole, then they've committed a new crime. So then they become reincarcerated, but they're awaiting trial.
So they fit more than one definition.
Means an individual.
Because they've already been sentenced for another crime.
Maybe an individual incarcerated while awaiting trial regardless of previous convictions.
We gotta work with DOC on this. DOC has weird structures.
I didn't have any concerns with the language as it was written, because if someone were sentenced and then they were detained for a new crime, we would be providing them healthcare regardless. Or if someone were already incarcerated and they had dual statuses, if they were sentenced, we would be providing them healthcare as an offender rather than a detainee, even though they are within both statuses.
So this is only used in this subchapter, which pertains just to medical care.
Yes. Can I confirm that? It does only apply to this subchapter, but I want to pull up what else is in this subchapter. Okay. Care of inmates. I'm gonna share this screen so you can see.
Yeah.
Last February.
So this is a subchapter that it applies to. Care of inmates.
So it's for everything,
It's not for everything, but
almost everything. So if you do the definition of detainee the way it is, then it would fall through from 801 all the way through to
it's not used anywhere else, though.
the term detainee, but it impacts these other places.
I mean, it only applies when the word detainee is used. So,
But we don't have a definite, right now, it is inmate that is used for detainees.
parentage is 28. Oh, it's been repealed. Oh, no, it will be repealed. But it's outside this subchapter. So there are no instances in that subchapter where detainee is used. So you,
But there is parts of that subchapter that pertain to detainees because they're defined as inmates. Inmates are detainees, offenders are inmates and sentenced. Because when you're looking at providing ID, it's different for folks who are detained or sentenced. And I don't know if there's treatments that are offered more to offenders than detainees if they've been in there for a short period of time. There's some differences.
Certainly for medication planning upon discharge, which I know we've testified to. And
Right. There's some real differences, but that would be under 801 and 801B, right? Something we're gonna have to be very careful in. And I know some of the new members may be lost. Or not.
Well, this is a hard enough work. I have to have another cookie.
How to take care of you, Kevin.
Kevin.
But you're on,
you like
you're
one?
on first. No, I've had three. I had three.
Okay.
I think we need to work with DOC in terms of this definition.
There's nothing concerning to us in the draft about using the word detainee, obviously, because we use it so frequently within the department, and we are gonna be providing medical care to anyone in our custody, regardless of their status. I just don't know if it presents problems with inconsistencies in adding that definition into statute where it's not like elsewhere.
Do you have a lawyer on staff or
I was
you?
gonna say, as someone who's not a lawyer.
Right, do you have a lawyer on staff or do you work with the AG's office for your legal advice?
We have a general counsel and a staff attorney.
You might want to reach out, because quite often we would have your staff attorney come in and weigh in on
Yeah.
draft legislation to make sure it's in your world, to make sure it works, because it may work in our world, but your world is quite different. If you could reach out to your staff attorney, it would be very helpful. And then maybe we could schedule the person in.
Uh-oh.
No.
What do you want?
I have to come in and see the greatest committee in the entire building.
Yeah, I don't think so.
Thank you. We would agree.
Okay, let's keep going here.
Mhm.
And next, top of page 5, there was a conversation about not using the term third-party medical provider contract. Instead, external medical provider contracts. So that's the term used there.
Yeah. Is that, why is that such a difference that needs to be made? Is that just like cleaning up statutory language right now?
The committee, I believe, felt uncomfortable with third party.
Because we were the third party would be someone outside of DOC and outside the facility. Is what really we're referring to, and that's why it's called external medical provider contacts. Because you could have a third party within corrections, but I think we're thinking of it more in terms it's outside the facility.
Could you not just say external third party?
We did, not, external
There.
third party.
Maybe non-governmental medical provider contracts. I mean, the idea is to signify that you're contracting with somebody that is not DOC. Could flag it. And then this section says that any contract between the department and a provider of physical or mental health services, and I've added in here, or substance use services, because that's a big part of what WellPath is contracted for, is to establish policies and procedures for continuation and provision of medication at the time of admission and thereafter, as determined by an appropriate evaluation by a healthcare practitioner, which will protect the health of inmates.
You have a question, Troy?
I don't think like, my question is, and thereafter, does that include upon release?
Where and thereafter.
Line 4.
Oh, yeah. Establish policies and procedures for the continuation and provision of medical time. Time of admission and thereafter. I mean, they are, in a sense, coming up with policies and procedures for both meanings of the word, because after admission is sort of your stay in a correctional facility. So you'd have provisions for that, but this also envisions what does reentry look like. And
Right.
so there would be
And you
provisions.
think it's included as the
I
reentry piece?
think it could be read that way. And if the committee is uncomfortable, I think it could be spelled out too. I think that both would work.
Yeah, I think what it probably meant was after admission, then while they're incarcerated.
Yes.
Provision of medication at the time of admission and thereafter. So this would, lines 1 through 3 would kick in at the time of admission, as well as when they are incarcerated.
But do we want to be inclusive? And I do of
Reentry.
I think it could be read that way because you
agree
have
with you.
statutory language that says that the person is to be provided
Yeah.
medication on exiting the facility.
I think I agree with you.
But I mean, the fact that we're having the conversation means that there's some ambiguity. So that it's never bad to, be more specific about what our intention is.
And the term reentry is for a limited period of time? Because it's just,
Like you'll see down here, I think it would include 12 days.
right,
This is for a non.
Mhm.
right. Thank you.
So let's flag that and see if we wanna.
Okay. Got it. So then we move on to subsection G. And this is the line 8 is what I'm very excited to correct. Except with regard to medication for opioid use disorder. So this is the paragraph that talks about what happens when somebody's reentering, what medication they can take with them. Right now, it's just talking about prescribed medication generally, not non-MUD medicine, which would mean that there is a reading of this in which somebody gets a 28-day supply of MOUD medication when they leave. So in order to be crystal clear about your intent, adding this line 8, except with regard to MOUD, if an offender or detainee takes a prescribed medication while incarcerated and that prescribed medication continues to be both available at the facility and clinically appropriate for the offender or detainee at the time of discharge from the correctional facility, the department shall provide the offender and may provide the detainee. We spent some time talking about that at the time of release with not less than a 28-day supply of the prescribed medication if possible to ensure that the offender or detainee may continue taking it as prescribed until the offender or detainee is able to fill a new prescription in the community. So that is why we have that split in terms of terminology with offender and detainee, because the obligation to provide medication when somebody is exiting a facility is different. For an offender, it's a shall, they have to. And then for a detainee who may not have been in the facility for very long, but could have been there, it's a may. So when the circumstances are right, the department may provide that medication, but they don't have an obligation to provide medication to every detainee who's exiting the facility.
So Haley, I'd like you really to work with your folks in DOC, and we'd like to schedule some time to go through this with DOC. Okay. Because we worked on this language last year for Connor and Troy and me and Mary and Gina. This came from us last year. Troy.
Yeah, my question is, and maybe we'll get into this, we don't need to right now, is do we need criteria for that may?
Oh, like under what circumstances? I
Or are
think
we
that's
just leaving that to the department? I don't know.
Well, it's the department, we have the department or its contractor. So why are we taking out its contractor?
That was a conversation the committee had when I was here, and the conversation was that the department, if not doing the work directly, has the obligation of making sure the work is being done. So that's why the committee decided to strike that.
Right, but in thinking it's the contractor that provides the offender. It's through the contract that the state has with the contractor. It's WellPath that provides the person upon the time of release with a 28-day supply. It's not the department.
A flip side to that argument, that you can hate, if you so choose to, is that the legal responsibility for making sure that happens lies with the state government entity. Yeah.
But what about if they have the contract with WellPath and it's in their contract? What we ended up doing with this language in one, we followed the language contract. That's what we did for that. So right now, even without this language here, WellPath in their contract is to provide a 28 or 30-day month supply of prescribed medication. What was happening was WellPath was basically giving the person a prescription. And it was really problematic for the person re-entering the community to, number one, even have a pharmacist that they could go to, a pharmacy that they could go to. Number two, if there was a pharmacy that the prescription got called into, the person had no insurance to pick it up, pay for it. So what we wanted to ensure was that there would be a supply of the medication given from WellPath and then a prescription to carry it through. But at least to physically have that medication in their pocket for 28 days. So folks who were here last year, help me out here.
Well, I think we can, I get where Katie's coming from. And I do, I mean, it's not an agreement, it's the state here that we have, that has the obligation, but can we say the department in conjunction with the contractor or through the contractor, or
It's the contractor that's providing it,
what is the obligation of the state?
the state.
Does it make one entity more liable than the other entity, depending on, yeah?
So here's my concern. If we add it here, say something like in conjunction with the contractor, then why wouldn't we be saying it everywhere in these two statutes? I just sort of mean that rhetorically, because then it's like, oh, we have to make sure an exam happens. It's not the department that's giving the exam, it's the WellPath. I'm trying to remember, did we talk about maybe adding? Here it is, page 11. The department may contract with an external medical provider pursuant to subsection 801F of this chapter to provide healthcare and substance use disorder services as required pursuant to this chapter.
Yeah, so it's the department that's providing it, but because of that, the way we provide it is through WellPath currently.
I
But I
think,
don't think we have to spell that out.
I think we could even like add another sentence or clause here if this is something the committee is concerned about, to say something like any any medical responsibilities or prescribing responsibilities given to the department shall be carried out by an entity that it's under contract with, something like that.
How does it work? Like, departments contract with all sorts of entities across state government,
Yeah.
right? Like DOL contracts with people to call you on the phone,
Yeah.
I think we generally say DOL in statute, right? Yeah.
Yeah.
But what you're referring to on page 11
There's a subsection I.
refers to the external medical provider contracts.
Yeah.
That's what you're referring to in the 801F. So it's a different contractor. The department may contract with an external medical provider pursuant to subsection 801F, which is at the top of page 5.
Mhm.
That's your third party
Mm-hmm.
that we wanted to do external.
Mm-hmm.
So that's a little different than WellPath. They're providing within the facility. They're not an external provider.
Mm-hmm.
So the way external is being used there, in my mind, is like non-governmental entity. External to state government,
Yeah.
not physically external.
Right.
I see the confusion.
But they're not an external provider. They're a provider within the correctional system. So an external provider, to me, is the third party, which is outside the facility.
Well, what Katie's pointing out is that it's a third party or external to DOC. They're hiring them, but I see where you're.
I see where the confusion is.
There's a lot of confusion because corrections has its own world. It's within the confines of the facility. It's its own world. they're not connected to the outside world that we are. So we have to be very, very careful on language in the world of corrections, because you're dealing with life within a facility. And it has all the nuances of life outside the facility, but it's carried out differently. Connor?
I don't want to derail it, but a question just popped up in my head that, before we go too far, does this statute apply to folks housed in Mississippi, which has a different healthcare
I
provider?
think the
Is it-
question would be, how do all of other Vermont statutes on corrections apply to somebody out of state? My guess is that they do, they travel with them, okay. That's interesting.
I feel like that makes this look a bit different, right?
Yeah.
Because if somebody is discharged from Mississippi,
No. No. If they are coming up for ending their sentence, or they will qualify for furlough or parole, they're brought back prior to this to a facility in Vermont. And it would be through that facility and WellPath at that facility when they re-enter the community. They're not re-entering the community from Mississippi. They're coming back here. They're going to be housed. In most cases, these are long-term sentences down there. In most cases, some of these folks are required to do some programming. And that programming doesn't start until about a year prior to their release date. In some cases, 2 years or 6 months or whatever. When it comes time for that programming to kick in, they're going to be coming back to a facility in Vermont. And that's when all the reentry planning, that's when their programming, all of that starts. So they're going to reenter the community from a Vermont facility, not from Mississippi. Am I off base on that, Ailey?
but some of this does apply to inside the facility.
Right.
And are we talking apples to apples here when we talk about the healthcare that's being provided to inmates in Mississippi?
And that would go towards the contract that we have with Mississippi, with CoreCivic. That would go towards that contract.
So I think it's worth just keeping an ear out for that as we're going through this bill to see, does it work with Mississippi?
So if they're admitted to a facility, they're not being admitted when they are arrested. They are not being admitted to Mississippi. They're being admitted to a facility in Vermont. When they are then incarcerated, and I'm looking down on G, the prescribed medication would all be taken care of while they're incarcerated in Vermont. Now, that then begs the question, if that medication is going to change for a variety of reasons, maybe the dosage is wrong, maybe there's too many side effects from it, and the person is now in Mississippi, who determines that? Haley, do you know?
It would not be WellPath, to my understanding, it would be the health provider in Mississippi.
And would they have to comply with Vermont law for that?
Yeah, I think it's the same statutory obligations. And as well as DOC policy that's outlined in our contract with CoreCivic.
So would they need to get approval from the medical provider here in Vermont to switch medication down there?
I don't think so, but I will confirm that.
Or with a healthcare practitioner? And is it licensed down there? Are there healthcare practitioners licensed down there? Do you know?
Yes, yeah,
Or-
no one would be prescribing medication that's not licensed to do that.
Or they'd be an inmate pretty quick.
It's true.
Anyways, 3 o'clock. We've only gotten to page 5,
Yeah.
and you have to be somewhere.
No, I'm good if you want to keep me a little bit.
Why don't we keep going a little bit?
Okay. Can I just tease this out? Sorry, I'm stuck where you are. But now we've created a definition that is somebody of a healthcare practitioner, that's somebody licensed or certified under Vermont law. So there isn't going to be somebody in Mississippi who's licensed or certified under Vermont law. They're going to be, I don't think that means that statute doesn't work. I think it means you might have to add something or equivalent licensure certification from whoever's certifying authority. I think.
This is where we also need DOC to really weigh in on this,
With the lawyer.
not leave it up to us neophytes. You need folks who work in DOC all the time, these nuances, layers.
Yeah, I also have the contract up with Core Civic, so I'm coming through it right now.
Can't be using these big words.
What?
Well, neophyte this time. I used superfluous all weekend because of you.
Okay. Can I keep going?
Yes.
Okay. We've made it to page 6.
I'm proud of you.
The department shall identify any necessary healthcare practitioner and schedule an intake appointment for the offender with the healthcare practitioner to ensure that the offender can continue care in the community as part of the offender's reentry plan. The department or its contractor may employ a caseworker or contract with a health navigator to assist in scheduling any healthcare appointments in the community. So here we are on line 6 referring to the contractor, because there was a discussion about the contractor could employ a caseworker.
Or contract with a caseworker. Because they may not have a caseworker in the facility, they would contract out with a caseworker.
I thought we went around in circles last time we met about the terminology here, about that you could contract with a caseworker. No, that you could employ a caseworker, but you had to contract with a health navigator. I thought that's what Isaac said.
Yeah, so the folks who oversee reentry planning in correctional facilities, their job title is called a caseworker.
Mhm.
I believe that language was added as part of our work with the 1115 waiver, because some of that coordinated care will be done by Vermont Chronic Care Initiative, and those are not employees of the department.
So you need to contract with a caseworker.
The caseworker would be the DOC
Would be
employee.
the DOC, so it'd be contracting
The health
with
navigator.
a health navigator. So what about a healthcare practitioner? Is that encompassing substance use disorder treatment programs?
Healthcare practitioner.
Because we've eliminated one thing, we did this last year. And we wanted to make sure,
You want to add an OTP in?
because we want to make sure they're hooked up with a program.
It's not here because we took it out on
We took it
purpose.
out.
Because it's in the second
Because it's in
section.
the opioids.
Yes.
section, but yeah, why did we put it in this section, folks, last year? Was that a mistake? We did this? Did we just carry it in both sections?
I'm wondering,
So
yeah,
I'll let
that's
you
why
know.
I'm wondering if we just didn't catch it.
We didn't catch
Yeah,
it.
it's not coming page.
But I don't know, that's, I don't remember the moment.
I know that Michelle was really the person who was focused on this, wanting to make sure that they were hooked to programs.
I think you were working with Ben.
No, but one of our committee members.
Oh, Michelle. Oh, okay. Sorry, I thought you meant Michelle Childs. I was like, I don't think she was the
It was
person.
Representative Bosley.
Okay.
It's really making sure that people were hooked up with treatment programs. This is for regular medication. It could be psychotropic medication, it could be blood pressure It could be ADHD, all the variety. So the department would need to identify a necessary healthcare practitioner and schedule an appointment for the offender with that practitioner. We okay with this?
I think it's, yeah,
Well, section 2, MOUD. People need to take a break, take a personal break. We're just gonna keep working here.
So in the title heading, I've added in substance use disorder because we have moved language on the SUD screening from the first section to the second section, which is not necessarily MOUD. So I wanted to be inclusive of all substance use disorder. And this language should look familiar in A. This is what has moved from the first section. Within 24 hours after admission to a correctional facility, each inmate shall be screened for substance use disorder by a healthcare practitioner as part of the initial and ongoing substance use screening and assessment process, including screening and assessment for opioid use disorders. In subsection B, the department shall determine whether an inmate is currently using medication prescribed in the course of MOUD pursuant to section 801 of this title. So we're cross-referencing back to the process that we put in place for all medications. An inmate receiving MOUD prior to entering the correctional facility shall be entitled to continue receiving that medication pending an evaluation by a healthcare practitioner licensed to prescribe the medication for as long as medically necessary.
can I jump in here?
Yeah.
So this is where I'm really starting to have my kind of radar tuned in for equity in and out. So if a person is being admitted into corrections and is already receiving MOUD, and let's just take it to the fact, let's say that they're receiving a once a month injected MOUD. Are we stipulating here that they are entitled to continue receiving that? You've got two that's that on
Should
page
we
7,
have
line
to
1.
continue
You've got two
receiving?
that's.
Yeah, on purpose, receiving that.
Oh, that medication.
But I take your point. Mhm.
Pending an evaluation. No, because after the comma there is for as long as medically. Continue receiving that medication for as long as medically. I think we just need that one of
Okay.
those that's on line 1.
Receiving that.
Where?
Line 1, page 7.
Page 7.
Oh, you're right. That, yeah, I got it.
Nonetheless, right, if this is where I really wonder about as medication for opioid use disorder or substance use disorder continues to evolve and improve and become cutting edge or best practice, I would like to require that somebody being admitted to DOC continues to receive whatever they were receiving on the outside. And right now, sticking point is going to be the cost of injected MOUDs.
Mhm.
I'm fine with that myself. I think I'm probably in small company, but
So if a person is doing the injectable on the outside and they're going through booking and they're admitted to a facility,
let's say they're 20 days away from their next injection.
right, but in B, the department needs to determine whether that person is currently using medication prescribed in the course of MOUD, and the person shall be entitled to continue receiving that medication, which means they would continue with the injectable, pending an evaluation by a healthcare practitioner licensed to prescribe the medication for as long as medically necessary.
I don't want us to switch if that's going to be disruptive to a person's treatment plan. that they had been receiving.
So is what is triggering you is pending an evaluation.
I
By a
just, well,
healthcare practitioner licensed to prescribe
Yes.
it for as long as medically. Because the first part of that sentence is pretty clear that if they're on an MOUD course and it is an injectable, they would be entitled to continue that
Yes.
medication.
so I'm doing two things. One, yes, the pending and evaluation concerns me. Two, alerting the committee to the fact that that's how I interpret section B.
We talked about the word that when I was last here, because I see that reading as indicating something specific, a specific mode of delivering the
Yeah.
medication. The testimony you heard from the Department of Health is not how they would read it. Well, Tony's here, so he could speak for himself, but I believe when referring to medication, it means the actual type of medication, methadone, buprenorphine, and not the way it's delivered. And if I got that wrong, please speak up.
Yeah,
Somebody-
Tony's on, he's on.
Stop sharing so I can,
Tony, you're gonna have to answer whether you want to or not.
sorry.
That's fine. Hi, everybody. Tony Fallon, Department of Health, Division of Substance Use. For the record, yes, the conversation we had was whether or not the medication delivery system or the medication itself, because the injectables, the two injectable products right now are either injectable naltrexone or injectable buprenorphine, both of which have oral or sublingual other mechanisms by which it can be delivered. So that was the conversation of, did the committee want to continue with the form by which the person receives it, the mechanism by which they receive it, or were they concerned about the medicine itself? If somebody goes into another facility, if they're seeing a practitioner who gives them an injectable and they go into a program that does not offer the injectable in the community, they're offered the oral medication or the sublingual medication as an alternative. So that was the conversation of, it's the same medicine. Are we focused on the delivery system or are we focused on the medicine? And that is for the committee to decide.
Are we focused on both? Or are we focused on one over the other? I think that some folks may be focused on both. Will looks confused. Sean?
Tony, does it make a difference if someone's getting it in getting in the injectable, getting an injection of either drug, and then they go into a facility, and let's say we switch them to the oral or the other way, you get it. You said some word, I don't know.
Under your tongue.
Yeah, under your tongue. Does that make a difference to that person? Like, does that change their trajectory of recovery? Or is it just, does it really affect them? Because I know it's really expensive. Like, I know the injections are super expensive, I guess, right? And I
The
know
injections-
Troy wants it, but I'm just medically speaking, does it make a difference? And if it doesn't make a difference, then to me, it should just go to the cheaper one. But anyway.
It's gonna be rumble
So,
in here.
and Tony,
Just,
Tony,
I know Troy.
I know.
Little Troy.
go ahead, Tony.
Yeah, I would say that depends on the individual. The primary different reasons why somebody might take an injectable format is, when I think about it logistically, the predominant reasons for people taking an injectable form is if they are unable, like their schedules don't allow them to see their provider regularly or get to a pharmacy regularly. So somebody who's traveling a lot, and once a month injection is much more simple than getting to a pharmacy because they can carry an injection with them. Secondly, somebody whose risk of diversion of the medication. So the medication itself works, but their lifestyle may be where they can't keep their medicine safe. So they might be unstably housed, or they might be living in a situation where that keeping that medication puts them at risk or puts others at risk. And the third reason, and this one where I think there is some potential for difference, is that some people really do well with the medicine, but they struggle with the taste or they struggle with sometimes dental issues because it's if you think of Suboxone, it is, I guess the easiest way I'd put it is probably tastes a lot like putting tang underneath your tongue. So it is a kind of a strong flavor, has some acidity to it, and it can be associated with dental issues for some individuals. So to bypass the dental concerns, you could conceivably put a person on an injectable, which reduces the kind of the nausea from taste as well as the dental concerns.
Interesting.
Okay, thank you.
Kevin and then Brian.
But if it's an injection, it's once a month. If it's the other, it may be more than once a month.
Every day.
It's every day.
Yeah, if it's an injection, it could be, so there are two different forms of injections for buprenorphine. One could be as often as weekly or out to once a month. The other would be oral medic or sublingual under your tongue medicine that it would be daily.
Daily. So that's another benefit to the injection.
Absolutely.
And that's where I'm coming in, and I'm thinking about DOC and what it actually costs to have all those people monitoring all that time.
And that whole line of people in the morning and all that, yeah.
Well, the diversion.
Yes, as well.
DOC is very interested in also offering injectables, but right now the cost is too prohibitive. We're unable to do that.
Unless we up your budget. Right?
Yes, which is not in the governor's recommended budget, although I know it's something that Representative Bloomley was very interested in, and I believe she was trying to advocate for some money through the opioid settlement funds. I don't believe that moved anywhere this year.
You mean our budget?
State
No,
budget.
state budget.
State budget,
No,
the big bill,
Big bill.
not the capital bill, the big bill.
We're paying it taxes.
Vermont, you mean, yeah.
Troy?
So I would love to hear some testimony from somebody who has received MOUD both ways and start getting some of that in here.
Good idea,
I
Troy.
would also, my biggest concern about this section, not a concern, what I'm mostly thinking about on this section is what it means for somebody who is receiving treatment on the outside, is incredibly successful with that treatment, to be disrupted, to have that treatment disrupted by becoming incarcerated. I just really want to be deliberate, and wherever we land, but I want us to do our due diligence on that question as we craft this policy.
Well, it's also in reverse too, not only for the person coming in, but going out. If they end up being on injectables while they're incarcerated for 5 years, and then they re-enter and the injectable is not available.
Because they can't afford it.
Lots to
Okay,
ponder.
let's move on. It's getting late. I don't know if we're gonna get through the whole bill, Katie.
Okay. We are on page 7, subsection C. That anytime an inmate screens positive as having an opioid use disorder, the inmate can elect to commence medication for opioid use disorder. That was a choice the committee made last time we met, not to necessarily start someone on buprenorphine specific. If it is deemed medically necessary by a healthcare practitioner licensed to prescribe the medication, the inmate shall be authorized to receive medication as soon as possible for as long as medically necessary. Subdivision 2, nothing in this subsection is to prevent an inmate who commences medication for opioid use disorder while in a correctional facility from transferring to a new medication. Previously, it said you could transfer from buprenorphine to methadone, but this removes the specifics, and this just talks about transferring from any MOUD medication to any other MOUD medication. That's prescribed in the course of MOUD if the new medication is deemed medically necessary by a healthcare practitioner licensed to prescribe the medication, and the inmate elects to commence the new medication as recommended by the healthcare practitioner licensed to prescribe. And on page 8, the healthcare practitioner, we're striking licensed because it's embedded in the definition. Healthcare practitioner who makes the clinical judgment to discontinue a medication prescribed in the course of medication for opioid use disorder shall cause the reason for the discontinuance to be entered into the inmate's medical record. And then the rest of that section is the same. I'm gonna.
So this is all upon admittance to a facility.
Mhm.
And that's why the term inmate is used.
Mm.
It is not about a person who is sentenced. This section is for folks who are admitted to a facility. Correct?
Because we're not distinguishing between two groups of people in a correctional facility here, the word inmate is used. It could be, well, it is offenders. It could possibly be detainees. It sort of leaves that to the discretion and the timing for DOC. But because the treatment is the same, the word inmate is used.
So all inmates are offenders, but not all offenders are inmates, or is it the other way around?
That's right.
Right?
Yeah, that's right.
All inmates are detainees and offenders, but offenders,
All offenders are inmates.
Right.
all
But not all
offenders.
inmates are offenders. Right?
No, because if you're out on furlough and you're in parole, you're still an offender.
Right.
You're not an inmate.
Yes.
That's what I'm trying to recall. That's what I'm trying to recall.
But it's.
So-
But it doesn't work for detainee.
Yeah, a detainee classifies as an inmate, but not as an offender
Yes.
yet.
So not guilty.
Maybe
So
not.
this only pertains to detainees, because we're only using inmate. Inmate shall be provided. It's not the offender.
I think in statute inmate does encompass both offender and detainee. Whereas offender is when we're just talking about the sentence population.
Just a sentenced. So inmate is for detainee and offender. And offender is just for sentenced.
We used incarcerated individual with the Kids Apart program.
Because of what?
In the Kids Apart program, we used incarcerated individual.
Yeah. I have another annoying language question, if I may.
Hmm?
Another annoying language question.
Well, it's a different world.
Oh, no, I meant I have a different one.
But I know what council is not agreeing on this, because I know
I'm not disagreeing. You just tell me what language
It's
makes
the
sense. I'm happy
terminology.
to work with whatever the committee decides.
so all inmates are detainees and offenders, or all inmates are detainees and sentenced. You know, where the term offender is used, is for sentenced folks. Because there's parts of DOC statutes that only deals with sentenced folks. So you need that differentiation. You gotta have that clarity.
I think you could walk through this section and sort of think through with the help of DOC. Okay, the first section has to do with somebody first coming into a correctional facility. We're doing a screening.
You mean A,
Is everybody screened, detainees and?
Yeah.
So everybody is screened. So
If they consent.
if they consent, okay, so inmate would capture everyone. And then subsection B, the department is to determine, okay, so this is sort of part of the second part of the screening is looking at whether medication, who's on medication. And I'm assuming everybody, they're checking for everybody coming in the doors. Okay, so that would be offenders and detainees. And C, this is looking at people who screened positive that they may elect to commence Medicaid for opioid use disorder if it's deemed medically necessary. So arguably, maybe there's some detainees that are not still there at this point, but if they are there and they had been, and they had screened positive, they could elect to choose.
Yeah.
So that would be inmate. Which would mean that they could transfer from one medication to the other. In subsection D, this is a decision to discontinue the medication. So the question is, does this language about discontinuance apply to offenders and detainees? Probably many detainees are gone by this point, but to the extent that they're still there, there's a decision to discontinue if that's medically appropriate. So that would be inmate. And then, oops,
Go ahead, Kevin.
This, I don't mean to put a monkey wrench in here, but do we ever have individuals that are incarcerated that are forced to take a medication?
No.
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 Okay, so then lines 8 and 9,
what page?
What page?
back up page 8.
Mhm.
The inmate has to provide authorization if the decision was to take them off the medication.
And that is authorization to share that with their community provider. So if at DOC, the medically necessary decision of a healthcare provider is to take a person off a medication, the inmate has the choice of whether or not they want the notice of the discontinuance given to their community provider.
If an inmate provides that signed authorization,
Right.
DOC would notify that community-based prescriber the decision to discontinue. If the inmate does not provide that signed authorization, the department will not notify the community-based prescriber that the person's been discontinued.
Yeah, that's the way I'm reading it. I'm just wondering why that provision is in there. Is there other statute that says that we can't tell the prescriber outside that it's no longer necessary?
It's the inmate's healthcare choice, just as it would be our choice.
But only if they've given us authorization.
It's the same for us
Yeah.
as well, right?
And the community were covered by HIPAA. So I don't know if WellPath is a covered entity. That's a good question. I've never given it thought.
I think they're covered by HIPAA.
They're covered by HIPAA, so that would be,
Covered by HIPAA.
that would necessitate
The signature.
signed, that would require permission to share that type of protected health information with the
So we
community
can
provider.
ask the outside provider whether they agree, but we can't tell the outside provider that they shouldn't be prescribed.
No.
No, I don't think so. I
Okay,
think
that's what I'm-
Whether or not we made
And
the
also-
decision, So just like in your own, like, so when you go to your primary care, like usually we sign paperwork at some point there and it says that you authorize them to share your pertinent medical information with other doctors. But if you don't sign that, they can't give you what, you go to your primary care and maybe you're going somewhere else, they can't share your records. It's against the law. You know, so you have to give them permission to share your records. It's all this stuff. Same thing. It's just giving DOC permission to share your records. The same way we do it. They're just, obviously ours is in this particular bill.
So the inmate's already given signed permission to receive the information. Therefore, they've got to give permission to get out the information, is what you're saying. Okay.
This is only permission to let the prescriber know, the community prescriber know that the person is no longer receiving the medication that they started.
Right, which I
Yeah.
would think would be advantageous, but if it's not
Oh,
legal.
like why do you need the signed authorization?
Right.
Got it. Okay. Yeah. Because it's the person's protected
Because of HIPAA.
health information.
All
But
right.
there's a lot of situations too where an inmate doesn't come in where they have a prescribed medication for opioid disorder. But upon screening and assessment, it's determined that they do have an opioid use disorder. And then DOC WellPath can get them started. on that. So then there's no notification of their outside medical provider if they have one, that the person has started on the MOUD program. There's no notification for that, right, Kaylee? Because the person on the outside wasn't prescribing anything. If there is a medical provider on the outside, because most times there is not. And if there is, person does come in on MOUD, then the person is hooked up either with some hub and spoke, or they have some medical provider there. And so the medical provider is the one that initially prescribed the MOUD. And once that person's incarcerated, if it's determined that they shouldn't be on it, then it's up to the inmate whether or not to relay that information to their provider.
I'm sorry.
You gotta go.
Needed elsewhere.
Yeah.
Just in time.
Well, no, I'm happy. It sounds like we'll be spending more quality time together. But somebody needs something from me.
So if you work with Phil to figure out when we can finish, we got plenty of time this week. I don't know what your schedule is.
Let me take a look.
And also you, Tony, if you could work with Phil. Because and I really want DOC. I know some of your folks are not available, but we really need, nothing against you, Haley. We need some folks.
Yeah.
Yeah, and also your legal staff as well.
I could do Friday morning.
Nothing before.
It depends how, well, maybe the floor will be short tomorrow.
Yeah, we don't have anything.
Okay.
Have anything on the floor tomorrow.
Unless it's
Before you
say
make-
History Day.
Before you make that decision, I have found out that Joe Asia could do the tour tomorrow. And if we don't do it tomorrow, then it'll have to be sometime next week. So you need to make a choice between those two things.
What's the weather for tomorrow?
The weather is not great, the high of 39 and a weather advisory beginning at 8 p.m.
What do folks want to do?
I'm game.
It's cold tomorrow.
It's cold tomorrow.
During the day,
Today, like
20, 21, 20.
I thought you said 39.
What is it next week?
Warmer next week.
75 and sunny.
No, I don't think so.
Instead of lollipops.
It was 70 in Bennington yesterday, believe it or not.
It does get warmer. It does get warmer tomorrow in the afternoon.
Is the sun out or is it cloudy?
The cloudy and in the upper 30s.
What do folks want to do?
I'm game either way, but if people are not comfortable with the cold, then I guess.
Thursday, it's raining-ish.
So tomorrow would be the only time, Katie?
Tomorrow I'm free until 2:45, between the floor and 2:45.
Okay, what else do you have on Thursday?
Thursday, 11:30 to 12. If you only have a short time on the floor, I've been told that my Thursday afternoon might cancel, but it hasn't yet, so that could be a possibility.
We have DOC coming in Thursday afternoon tentatively with a short floor.
On this?
No.
Oh. And then Friday, I have a lot of capacity.
In the morning.
In the morning, I could do the afternoon, let's see.
I won't be here.
Not possible, yeah.
You got a half day off.
Oh, you want to have to?
You're the
I
boss.
have to go to Senate institutions.
Okay. Just kidding. I'm also. So Friday morning. Yeah, and then a little bit tight.
What do folks want to do? Do you want to do the tour tomorrow afternoon?
I'm game, but I already said that, so I guess I didn't.
I'm hearing, I need to hear from folks.
I can do the tour tomorrow afternoon, if people are amenable to that.
What time were we thinking of leaving?
Maybe after the floor.
Got a noon thing tomorrow?
Yeah, but the floor's on at one.
Oh, okay. Yeah, I'd be good. I'd be good.
Those available beginning at 2. You've never been to Mount Playground.
Okay, well, why don't we do the tour tomorrow? But they have to get a four-wheeler.
I've mentioned that, but I haven't gotten a
Yeah,
response.
they have to work with Sergeant Arms. So Katie, maybe Friday or Thursday, if you find it, well, Nancy's gonna-
Oh, Friday morning is a
Do
possibility.
you wanna put it on my calendar and hold the time? Otherwise,
For Friday?
yeah, otherwise somebody else will take it.
Yes.
Okay.
On her calendar all the time.
For Friday morning.
Yeah, the only time you're busy, it says is at noon.
Yep. I have a meeting at noon, so if you wanna do Friday morning after the floor?
Yeah.
What time is the floor? 9:30, so
Yeah.
you want 10:30 to
10:30.
noon?
I believe in Katie.
Oh,
You guys like eat lunch?
Yeah.
Is that not?
Katie, Friday morning, 10:30 to.
That should be fine.
Yeah.
Okay,
Okay.
great.
Thanks, Katie.
Yeah, no problem.
Thank you.
You're welcome. Good to see everyone.
So that kind of wraps it up for part of today. We are gonna have to schedule in some folks to testify on this, and I want to get that kind of set up. I think it's really important to get some medical folks in here. I don't know if that's out of my world. But I don't know if we need OPR. That's through the Secretary of State's office. And anyone from
Yeah, sorry for a second to get those cookies.
the medical board, we just need some help here in terms of the medical world. And I'm just not sure who to go to for that.
Well, would Tony help us with that or?
Not, yes and no, it's yes, no.
Or maybe send us in the right direction?
Yeah, I'd be happy to help. Board of Medical Practice, the director is David Herlihy. I'm happy to reach out or do Phil, I think you may know David. And then for OPR, I'm assuming you would want probably Phyllis Mitchell, who's the director of the Board of Nursing, I would think. So she would oversee APRNs, and a lot of the conversation we had was about scope of practice.
So did you get those two names, Bill?
I did.
Let's start there. And Tony, if you can think of other folks that might help, if you could just connect with Phil on that.
Absolutely.
And does Friday morning work for you at 10:30?
I will make that work, Madam Chair.
Thank you.
Absolutely.
Appreciate it. Then we can at least get through this first draft.
Mhm.
So that's it for now. Let's go. We're done on YouTube. Let's go off of YouTube, and Tony, we'll see you on Friday.
Thank you very much, everybody,
Okay.
for
Thank you,
having me.
Tony.
Thanks.